We'd like to welcome you to the Healthcare Revolution podcast, where we empower you to take control of your health, restore your trust in the medical system, and achieve lasting wellness. I am your host, Brad Powell, Doctor of Physical Therapy and owner of an award-winning foundation physical therapy here in the Salt Lake Valley. Each episode, we dive into all things rehab prevention, overall health, bringing you expert insights from leaders across the healthcare fields. Please note, while we aim to provide with the best knowledge and advice, the opinions shared represent those of experts in the field and are not to be replaced with professional medical advice. So let's revolutionize healthcare and wellness together. Well, welcome to the Healthcare Revolution podcast. We are so excited to have our guest today here. We are talking about the Multifidus, which is the missing link in low back pain. And today we have with us Dr. KyleKiesel and Dr. Jeremy Joyal. We're so excited to have these guests on. I just want to give just a brief introduction of the caliber of people that are in the room with us today. Dr. KyleKiesel is one of the most influential leaders in modern spine care and movement science, with over 20 years in academia, more than 40 peer-reviewed publications, and internationally recognized research on multifidus dysfunction and motor control. We'll talk about what those things are throughout the podcast. But he's an expert in this area. He's developed the functional movement assessment, so it's SFMA, used by elite sports teams and military programs worldwide. And we're so excited to have him join us and to share his expertise. So welcome, Kyle, to the podcast.
Yeah, thanks a lot for having me here, and great to be with Dr. Joyal and have an opportunity to share kind of our background and where we're going with back pain. And I just wanted to say thanks for everything you're doing, and congrats on your clinical success. Super important that we get new, fresh outpatient physical therapy clinics and approaches and theoretical approaches and the things that you're doing to take care of patients. So I appreciate that. I was able to meet a few of your therapists already, and super job leading them. So congrats on that, and keep up the good work there.
Well, thank you. And we also have Dr. Jeremy Joyal. He's a triple board certified physician in anesthesiology, pain medicine, and addiction medicine. He's trained at the top institutions, including Washington University in St. Louis and the University of Utah. He is the founder of Advanced Spine and Pain, and he leads one of Utah's most progressive pain clinics, specializing in evidence-based, non-opioid, non-surgical solutions for complex spine conditions. And together, these two really represent the perfect example of what we're trying to create in the community. It's this collaborative based care of everyone working together for the best outcomes of the patient. So excited for our journey today and what we're going to accomplish. Kyle, tell us, and welcome Jeremy to the podcast. So good to have you on.
Thanks. It's a little overdue, but we're here.
I'd say it's overdue. Jeremy's been a good friend for years. I call Jeremy anytime I'm just stuck with a patient. I'm like, I have a patient that just can barely walk, and I'm working, trying to get their pain modulator, getting their pain down. Can't do it. Call up Jeremy on his cell phone. I'm like, Jeremy, bail me out, man. I need help. He'll get them in a day or two. He makes it happen and gets these people pain relief really quickly, and just so grateful for all you do for our patients and for the community.
It works out well working together. So
we both were at we both won the award, the best Salt Lake City clinics.
Nice.
This last year.
Yeah.
And it was fun to be at that event together with our families and friends. It was awesome.
Yeah.
So Kyle, tell us about the multifidus muscle. We're making a promise to our listeners today that by the end of this episode, you'll know more clearly about how this muscle helps you, especially with chronic low back pain, and how PTs and physicians can help you guide you through that process. Because chronic low back pain, we really define as more than 90 days of low back pain, and some people have this for years. So we're talking about this missing link, this multifidus muscle. Tell us what the multifidus muscle does, and what you've done in the research world to learn more about it.
Yeah, for sure. Super important that we think about motor control of the spine as a whole, so how the muscles control the spine. And it just happens to be one of the muscles, the multifidus, sits deep in your spine, is sort of the orchestrate leader, kind of runs the show, if you will, the conductor of the spinal muscles. We've learned that through research over the years. And when we look at one muscle, you're kind of like, well, gosh, how can one muscle be so important? And it is mostly because it sits right next to the spine and it's loaded with sensors. So we think of muscles as producing movement and being strong and power. They also have sensors that tell the brain what's going on. The brain cares about movement, and the complexity of the spine, looking at using all your core muscles and hips and ankles and everything together to move, the brain needs that information. So this little muscle in your spine helps stabilize, and that's what we talk about with patients. But when we unpack it one more layer, it's actually a sensory organ telling the brain what's going on. And unfortunately, the way the body works when there's pain, so any kind of back pain, you could injure your back a variety of ways, it tends to shut down that particular muscle. And there's a whole scientific rationale behind it. But when you think about patients that you've seen in the community, if you've ever had a knee injury, that big muscle in the front of your thigh, that quadricep muscle, goes through the same thing. It shuts down automatically. So whether we're in sports medicine or working with a total knee patient, we have to get that quadricep back. Same mechanism biologically shuts down multifidus. So
tell us why that happens. Why does when your body is in pain, why does we use the muscle inhibition? It slows down the signal and shuts down the muscle. Why does the body do that when it's in pain?
Super important to understand that key point. It's inhibition. So the neural drive, or the body's signal to get the muscle to contract, shuts down. We think the reason is just embedded in biology to protect the area. So when one muscle selectively shuts down that's loaded with sensors like the multifidus, the brain recognizes a problem and splints the back with other muscle activation. So you get this mass activation of muscles around your core to protect that injured area. So like a lot of biological processes, the good intention, we're trying to protect an injured area. Unfortunately, that good intended biological mechanism can linger and continue. So a lot of patients, when their back starts feeling better, that muscle doesn't quite recover. And so when we say that the kind of hidden problem with back pain, it's because the muscle, that patients feel better, but the muscle doesn't recover. And that starts them on their journey. 2/3 of back pain patients go on this journey of waxing and waning. They feel better for a while, and then they have a setback.
Yeah.
They go to physical therapy, they get a little better, have another setback, and they go through this waxing and waning and eventually end up with axial back pain that is debilitating, and it can all be driven from this motor control change we see in multifidus.
Yeah, and we look at this muscle, and my question for you, Dr. Joyal, is when we look at this muscle on an MRI, and it's been stuck in this chronic phase for so long, what does it look like? You just showed me a picture this morning. The muscle looks different on MRI. Explain that to us.
Yeah, if you're used to looking at red meat under cellophane in the grocery store, the analogy fits in what it looks like on an MRI. A nice healthy muscle just looks like a filet mignon, all red meat, very little fatty infiltration through those muscle fibers. And then advanced stage atrophy on an MRI will have some dark fibers on the image intermixed with a lot of white fatty fibers as well. So that's going to be more like your ribeye, So that's what it looks like just in black and white.
And a normal muscle is just nice and red and plump and healthy. But then on the MRI of these patients with chronic low back pain, you get these fatty deposits where you see the white area.
Correct.
Right?
Yeah. And when I first learned about Reactivate, the treatment that restores multifidus muscle dysfunction, I started screening all my patients' MRIs for atrophy, and virtually, I gave up after a few weeks because virtually every MRI that I reviewed had some degree of atrophy, because by the time they come see me, most people have kind of suffered through it and just try to figure out on their own. They've probably worked with their primary care doctor for quite a while as well. Try some anti-inflammatories, muscle relaxants, steroid packs, things of that nature. And they've probably worked with folks in your discipline as well. We don't jump into interventional care right away. We got to, escalate the care as appropriate. And so by the time I stopped tracking which patients had atrophy, because it virtually 99% of the patients that walk through our doors are essentially candidates.
Yeah, we're going to talk about Reactivate and the challenges that you face with insurance and covering this. But essentially, Reactivate is a neuromuscular electrical stimulation unit that's put internally, and you can correct me if I'm wrong, but that stimulates the muscle to activate it more, to essentially get rid of the fatty deposits and make the tissue more healthy. Let's jump onto this for a minute. The reactivate, once you implant it, how long is it stay implanted, and what does the tissue look like differently over time?
So the device is implanted in a short outpatient surgery. Takes about 45 minutes to implant through 2 small incisions. Post-operatively, we let patients rest for 2 weeks. We don't actually use the device until they've had some rest and recovery. And then the use of the device is twice a day. Patients will activate the device themselves with a remote control. And for 30 minutes after the activation, it'll do a perfect contraction relaxation exercise of the multifidus muscle. So you get perfect exercise with the click of a button twice a day, and you don't even break a sweat.
Do they perform an exercise while they're turning it on?
No, they're laying in bed.
Okay.
So they either lay on their stomach or on their side where it's most comfortable.
Yeah, and in the rehab world, Kyle, this, we put electrical stimulation units on the quadriceps. So we're talking about knee pain again. We put it on the quad because the quadricep muscle gets really atrophied. The muscle activation gets significantly less because there's that inhibition because of pain. So we'll put little sticky pads with an electrical stimulation unit, and that's different than your typical feel-good electrical stimulation. This is a lot more intense. We crank it up as much as you can tolerate, and we'll have them squeeze the muscle as they turn it on. It turns on, and then relax the muscle in a certain sequence. And it can be extremely helpful, especially post-operatively. So
yeah, for sure. And that was the idea of the genesis of Reactivate, was the same idea, to stimulate the muscle, because the literature was clear. Muscle dysfunction was driving a lot of these back pain patients. And the problem with multifidus, it's layered, so you can touch the superficial layer and put electrode on that over the skin. But the deep layer is really what counts. That's where all the proprioceptive fibers are. To get to the deep layer, we had to do a little differently.
And when we're talking proprioceptive fibers, that's really what you were talking about earlier. It's the communication signals that are going to the brain. So that's just a fancy term that we use for communication, little receptors in your muscles to tell your brain what's happening.
Yeah, that contraction, when those muscle spindles that have the little receptors, the sensors, tell the brain what's going on, everything can flow. When those get shut down, things change and things become dysfunctional. So,
and I love the comparison of the body with a computer. Our bodies are intelligent computers, but we all know computers dysfunction sometimes, and sometimes you got to shut the thing off and restart it. And sometimes you got to retrain things or recode things, and this is essentially part of that process.
Yeah, I mean, initially when there's pain and that signal shuts down, if you want the analogy, you have a software problem. The information's not getting to the brain can't run the system. But because the muscle stays shut down and this degenerative process in the muscle starts, and that can take 6 months to a year, by the time we get patients in, you also have a hardware problem. So we can fix both, really, and we need to, and that's what we do with Reactivate. So the reason it takes more than putting the electrodes on your quad, for an example, is we've got to get to the nerve that feeds the muscle. Because when you stimulate the muscle itself, the quality of the contraction and that brain signal is different. The brain's like, what's going on with this foreign stimulation? When you stimulate the nerve, it takes just a tiny bit of current, so patient feels comfortable. You don't feel that really pain and discomfort when you do it in the quadricep with patients.
Yeah. It's
very comfortable. The nerve then simply sends the natural signal to the muscle to contract. So the muscle receptor doesn't know that it's an artificial stimulus.
I see.
Right. So we're kind of tricking the brain in that sense. But I think the whole secret here is stimulate the nerve to the muscle. And then we just use regular exercise
so you're
parameters,
actually
like
not
Dr.
putting
Joyal said.
The electrical stimulation on the muscle at all. It's on the nerve that feeds the muscle.
Absolutely. The target is the nerve. And so...
Do you see more carryover when you're targeting the nerve versus the muscle?
Well, when you look at research, when we try to target the multifidus muscle with a cutaneous or a electrode over the skin, it's not the same. Like the muscle contraction's different. To your point, about the time you get a good contraction, it's painful. And so it's challenging to be compliant. And the other thing, maybe the most important thing, is when we stimulate the nerve to the muscle, we get this nice natural contraction. And these patients with chronic axial back pain, let's say you've had it a year or more, it can take 2 to 3 months of doing this therapy twice a day, 30 minutes. You're getting 120 perfect contractions, not interfered with any of the noise and compensations, and it still takes 3 months. So I think even if putting the electrodes on worked on your skin, I just don't think we'd be compliant with that for 3 months in a row, twice a day, every
Hard
day,
to be consistent.
and it's uncomfortable.
Yeah.
And so we've learned that even though it's a little bit of a lift to do the procedure, it's worth it because we're getting a nice perfect contraction. And remember, that contraction certainly helps the muscle do its job from a muscle strength perspective. But remember, the sensation is getting restored.
That's awesome.
And so the other muscles in your body start getting better and normalize. And we hear this in patients at 2 months, sitting a little straighter, got a little better affect, I'm moving better, but my back hurts. And we're like, you're doing great, keep using the device. I'll see you in a couple more months. We see at 4 months, super happy, I got it, I'm using it every day, I'm moving better, and I'm feeling better. 6 months, check the box, pain's down where we want it, pretty much back to function.
That's amazing.
So, but the point is, it takes that long, and 120 perfect contractions a day for 3 to 6 months is what we're looking at.
It's so powerful for another topic that we've covered in the past on the podcast: pain sensitization, right? Because we have multifidi, this muscle not working well, but then your nervous system is just hyper alert. So this can be a powerful tool for desensitizing some of the signals that are going on.
I think there's a couple things there. That is certainly what's happening in a subset of these chronic back pain patients. I think not all of them really have too dramatic of a representation of that. Some do. The treatment that we recommend is they utilize it one session at night, and they all describe it as massage-like and soothing. So it calms them down, it soothes things, it de-emphasizes the signals, as you say, and I think that's part of it. The other part is, for years, these patients have had chronic back pain. It's controlled their life. They go to providers that do something to them. Now they have an opportunity to control their back pain through their device. So we hear this language.
It's empowering.
Yeah, absolutely. We hear this language like, I do my sessions this way. I take my activator with me on everywhere I go, every vacation, so I can do my sessions. Here's how I'm using it. It's working for me. So it becomes part of a solution for them that they're part of. And I think there certainly is a psychological piece with that. We haven't studied it, but I suspect there's something there.
Well, yeah, there's studies that I've looked at that really look at different ethnicities and their perception of pain. And all different ethnicities have different perceptions of pain, right? But what we noticed in these studies is that it was tied to what we call locus of control. You've heard that as a researcher, and Jeremy, I'm sure you've heard that as well. The more control the patient has, the less perceived pain they have.
Yeah.
So the more they have empowerment and control of their life, the more or the less pain they actually have, which is pretty incredible.
Yeah, and what we see with these patients is they start to get more functional, and they literally, I'll say it again, they're sitting up straighter, standing in taller, their affect's a little better, they're getting on off the table better. Like, I'm doing more, but my back still hurts. So I think they're just exchanging more function and don't mind the pain for a while, and then eventually the pain catches up. So we feel like we're restoring motor control. We provide functional return, pain reduction, sort of a byproduct of that, honestly. So,
and Dr. Joyal, I've loved this journey being with you. Being a physical therapist and a pain physician that just respect each other and help each other. When did you get to the point where you're like, I need to use a Reactivate device to help these patients? Like, what was this story, this journey that you've been on?
The aha moment for me was listening to Kyle's research. It was a new, I hate to use a buzzword, but a paradigm shift in how we treat chronic back pain, because we always, in the medicine world, we always look at it from the structural elements, the discs, the facet joints, the spinal canal, the foramina, the end plates. And that's how we've treated. That's the only thing we've been able to really diagnose as structural defects in our world. you guys are used to doing the functional assessments. That's not taught in MD-DO school. Well, probably more in DO school, but nevertheless.
A little bit.
Little bit, a glimpse. So nevertheless, when I started, I was taught in school, you only see what you look for,
So true.
And so we weren't looking for that in our profession. And then once we started looking for it, it's everywhere, So the research is super compelling. It's changing how I think we should deliver care. Just contrasting this Reactivate device that actually restores function directly. I contrast that with something that we know will impair that function of that same muscle, the multifidus muscle. So we do a treatment called the lumbar radiofrequency ablation, which deadens the medial branch nerve, which is in charge of sending pain signals from the joints of the spine called facet joints, but it also weakens that very muscle we're talking about, the multifidus.
It decreases the signal to contract the muscle, essentially.
Correct. So we are inducing some pain relief, but we're also inducing some muscle inhibition, and we know
Which
that...
is kind of like, in your mind as a physician, you're like, it's kind of a conflict. Like, I'm deadening the pain, but I'm also decreasing the function of the ability to stabilize. You're like,
Correct. Correct. And they did a really cool sheep study where they took healthy sheep, did a hypertonic saline injection into the disc, I believe, wasn't it?
Lesion the disc,
Lesion
actually.
the disc.
Created a disc injury. Yeah.
And then tracked
Poor sheep.
I know.
Got back pain now.
and then they looked at the structural changes under the microscope of what happens, and within 6 months of that injury, the muscle started to develop scar tissue fibrosis. And fibrosis is not going to heal with it's there. It's not going to be reversed. And so up until this point where Reactivate's been commercially available, the best we had for chronic low back pain that wouldn't respond to, basic medications, activity modifications, and good PT, and good effort on the patients on their own input into their healing. The next step was to sacrifice something that was, causing the pain, these medial branch nerves, in hopes that they get enough pain relief that they can extend their rehab beyond what pain was limiting prior to that treatment.
Yeah.
And so now what we're trying to do in our clinic is, introduce the idea of this functional treatment rather than a structural treatment as soon as we see them. And then we've got, patient selection. Patients should have the option to pursue the treatments that they like. Our job is to lay out the brochures of, the different treatments and let them get educated and then choose their paths. And, it's a little bit challenging when insurances stop patients from getting good therapy.
The thorn in all of our sides.
Yes, yes. And so that's the biggest challenge we have right now. What we've found is that as we've changed our talk track with our patients, introducing this procedure earlier, it has been accepted really quickly by a lot of our patients. In fact, this is the first procedure I do on patients if they choose to do that.
Because it's minimally invasive.
Yep.
It doesn't really cause harm. Have you
It's
found any
reversible.
studies that it's caused any harm at all, other than potentially a small % of infection, maybe?
That's essentially it. There were a few explants due to
we love
infection.
things that have no harm, right? You ever listen to those commercials on medication, and you're like, it just lists on and death, and you're like, all right, definitely want to take that medication. But you're telling me this device has almost no issues, no harm that it can cause. It's only positive.
Yeah, that's the way the research looks. We track everything, of course, when we're under government research. So there's some side effects from it. We have a handful of infections, occasionally, if you move wrong, the lead can get fractured. So I can't say zero. I wouldn't say zero.
Yeah.
Super low and very consistent with other implantable devices. And when you weigh the outcomes we're getting, the outcomes are very comfortable saying the outcomes are better than anything else we have right now as an implantable device for axial low back pain.
Yeah.
And these patients, they're at the end. They've tried physical therapy. They've tried injections. Most of these patients, really, there's not a true other surgical intervention that would make sense.
Yeah, these are typically the people that are just they've maxed out every option.
Yeah.
And this is another option for them. Tell us, Dr. Joyal, what can patients do? You talked about the difficulty with insurance. What can our patients do if they do decide that Reactivate is a tool that they want to use in the future? What can they do to convince insurance companies that this is something that is going to be beneficial for them?
I think it's important that patients get involved in this process. So, having their voice sent to the medical directors and whatnot has been helpful in some cases where they're just not reading our reports, not the doctor's notes and the PT notes and the imaging summaries, So we encourage them to write a personal letter to add to the stack of papers, because sometimes we have to convince them with every means possible, and that's including 20 years of research studies, the animal studies, the clinical studies, the reviews and all those things. But having a personal connection, I think for some people can be helpful. I've had some...
and I'd add to that, we've done podcasts in the past about what insurance companies really look for, and they actually lean on patients to tell them how to navigate, right? So if they get a bunch of calls in from patients consistently complaining about not getting Reactivate, they listen, because the customer is the patient and they want to protect the customer, but they look for patterns, and they get enough patterns, enough complaints over time, they change their minds.
Yeah.
So it can be extremely beneficial for patients calling in and giving their side of the story.
Absolutely. So it's a little bit of a war of attrition we're fighting, But another thing that's been helpful in some cases is some of our patients work for really large companies that have self-funded plans that are managed by some of the commercial payers. So they can, if the patient's in that situation, they can go to their director of HR and say, hey, this management company is not providing the care I need. I'm your employee. I need to work for you. If you want me to continue to work, I need some help getting this done. We had some overturns with that method, going straight to HR.
Yeah, that's
as well.
great.
So,
and from a national level, we've done so much research with this. I mean, it's multiple randomized trials, big studies, big review. Over 650 patients just came out showing how well it works. So we are moving insurance companies, and I will say that earlier this year that we did get one coverage policy from a large national commercial company. So that was a big win for us, because this works, and they know
Medicare, TRICARE,
certainly
sounds like
Medicare coverage is good, TRICARE is good, VA is good.
Which is interesting because Medicare, if they cover it, usually all the other commercial insurances follow suit.
A little bit. It kind of depends on the codes that they use in that, so you can get in the weeds pretty quick on that. But if you do have commercial insurance and things, we would encourage you to submit that, and our company and say Dr. Joyal's office help you with that fight. We've got that down, and because we've made this progress, we have a good research. We've got so many impact statements from patients over the years. There's a good chance you get that overturned and continue to help this therapy be more accessible to people who need it. So
and just so everyone knows, the levels of research Kyle talked about, randomized control trial. We kind of think about this triangle, like what's the top tier research out there? Professional opinion is technically the lowest, one of the lowest levels. It is research, right? It's evidence as a professional opinion, but that's one of the lower tiers. So when we're talking randomized control trials, systematic reviews, this is the top tier research in the world. So, I mean, Kyle's saying we have, plenty of studies that support this and say that it's very beneficial.
Yeah, for sure. And through randomized trials, cohort studies, randomized trials, and then these systematic reviews that take all the studies, kind of level play them for different variables within the study, and then analyze the outcome. So instead of having one study of a couple hundred people, you've got a systematic way to look at 600 people that have had the therapy.
Yeah,
and we can look at their outcomes.
Out of all the studies that you've done, what are kind of your top research projects that you've worked on?
Well, this has been very rewarding, because what has motivated me to stay involved in this since the very beginning was my dissertation work way back in the day. We're talking 25 years ago. I was looking at multifidus muscle and how do we retrain it and how do we measure it. And so I would help patients like you do in the clinic every day, and then a few would slip through the cracks. The ones I just wasn't quite comfortable. They're better, they're happy, they're seeing us, but I knew we weren't solving their problem. Yeah. And so the founder of the company had the idea back in 2009, called me and said, hey, what about stimulating the muscle in some of these patients? I think it's a great idea, because there's a handful that are slipping through the cracks. And at that time, this is 20 years ago, these patients would knock on some doors. There wasn't as many physicians like Dr. Joyal that can do minimally invasive things. So a lot of them were getting big surgeries for a smaller type structural problem. And so I've been motivated to stay involved with that.
When you talk big surgeries, I just saw one Dr. Joyal showed me, like multi-levels, 5-level fusion with the SI joint fused. We're not talking a small surgery.
Yeah,
These
and
are
those
big
surgeries
ones.
are important for people that we need them. But if you've got sort of axial back pain, it's not shooting down your leg, and you're having functional problems with that, and it's not getting better, then those big surgeries aren't necessarily the answer. So there's time for those. They're important. But I stayed involved with this. So some of the most satisfying research we've done is seeing it come to fruition now that I'm in the field with these patients, seeing these patients, training the people in the company that work with patients to identify them and help these patients get the right care. So that's been really the most satisfying. It's pretty unusual for a researcher to be involved in the beginning on really kind of some foundational stuff and then see it through to the end. And I guess that speaks to my age a little bit as well. It's been a number of years, but it's been good to see it, and I love now being in the field to just connect with these patients.
Yeah, I graduated about 6 years ago, and in my doctoral program we looked at your work extensively.
Nice.
And we spent 3 weeks getting certified in selective functional movement assessment. And I was telling you this morning, it has been the most powerful tool I've used in clinical practice. And we'll spend some time talking about SFMA here in a minute and how we utilize that for our patients. But is there any studies that you would suggest to our listeners to go check out on these topics?
Well, I think honestly the companies that have these products or these therapies have good websites, and they have all the information there. It's very easy to read. And because we are controlled by the FDA, we can't just put what we want, right? This gets vetted by rules that we have to follow, which we want to follow and give good information. So I am comfortable guiding you to the website because the information is accurate. For a person to go onto PubMed and dig up a study and read the study and find there's some challenges with that, but they're all out there. It's very transparent. All our stuff's peer-reviewed, and so the other thing with this, I'm very proud of the quality of the research that we have done with this. When you have a new device, sometimes there's a rush to get it to market, and that can cause you to make some decisions, behind the scenes that aren't necessarily in good faith long term. And with Reactivate, working with folks like Dr. Joyal, we've teamed up with good folks, and we're doing it right. So very comfortable in the information you can find online. So
that's awesome. So tell me about selective functional movement assessment. What started it? What is it? How do we use it in practice? And then I want to go to Dr. Joyal and hear, how does this make sense to him in his practice?
Yeah. So in my beginning of my world, I was studying one little muscle in a research side. And then clinically, functionally, we were working with the whole body. And so how your neck moves and your ankle moves and your hip move, that makes a difference on how your back responds to that. And so I was studying one little muscle. I had one little muscle on one shoulder, and my mentor, Gray Cook, on the other shoulder saying, look at the toe touch. And I'm like, look at the little muscle. Look at the rotation pattern. Look at the little muscle. And I was like, these people are saying the same thing. The little muscle drives all these problems that we're seeing. So when we go to treat the muscle, you can't just strengthen it up and get it better. You have to look at the whole body. And that's where we were able to develop tools to look at full body movement patterns in a very efficient clinical way. So whether you come in with low back pain or knee pain, I care about if you can touch your toes and what that looks like. And I care about your balance. I care about your neck. I care about your ankle. Everything is connected. And so we have trained, as we were saying, thousands of therapists to look at the full body when you're doing the rehabilitation process of anything. You've just got to get the microscope off the pain generator and look at that bigger picture. And so that was a clinical tool to be able to do that. I'm glad you found it. You are finding it useful. So
like I said, I use it almost every day in clinical practice. So let's just break down one movement. So you have multi-segmental flexion, which is just say go down and touch your toes, and then you have multi-segmental extension, which is extend back. What are the pieces that you're looking for when someone goes and bends and touches their toes?
Well, yeah. So because the full movements are so important in rehabilitation, different models would use observations. Yeah, it looks pretty good to me. And then next guy would come in, that doesn't look so good to me. And we didn't have a standard of what quality movement was. So we set out from the beginning, this is 30 years ago, to standardize this movement assessment. So when you ask me that question, what do I look for in a toe touch? I'm going to tell you the criteria that make a quote, good toe touch. We just call it functional. It's good enough.
Yeah,
right?
Which is like it's a standard, right?
It's a standard, yeah.
Physical therapists have struggled over years of having a criteria to base what we do.
Yeah.
There's so much of what we do, but we have a hard time explaining it. But SFMA has a list. It's like, okay, you touch your toes. Here are the criteria that we're looking for as you touch your toes to determine if you have an issue.
Standardize it. So whether I'm teaching overseas in another language or right here with you, the toe touch is the same, and it's a standardized thing. It's not a quality movement. And we can research it. It's hard to research. Looks pretty good, or not, right? So
it could be so subjective versus objective.
And so what drove me, one of the things that drove me to do the research on all this is to get the training is to understand the research. So to standardize something that we can score it the same way is fundamentally reliability in a measurement. It's fundamentals of measurement. And that's the first step before we can research anything. So the toe touch, you go down, we want you to be able to get your fingertips to your toes. Like body relative, we just think humans should be able to touch their toes. If you can't, you get a little check against you. It's not the end of the world. That's number one.
We make sure to say that out loud, too. That's one check.
Check. The checks can add up in some people, unfortunately, over the years, which is a wellness topic. We'll stay away from that one for today.
So I can preface this, there's an actual form that you go through, and you have people go through various movements, and they meet the criteria. They're good.
They're good.
It's a check, right? Or versus an X. An X is like, oh, you're not able to do that portion of the criteria well. And we have similar criteria with return to sport athletes. Someone tears their ACL. Here is the criteria based on the research that you need to pass off in order to return to sport safely. And if you can do those things, the likelihood of re-tearing is significantly less based on the research. So that's why we use standardized testing to help us determine if you're actually ready for that. So this is standardized testing to say, let's standardize the movement, and that movement is associated with this impairment. Therefore, we're going to work on that movement.
Yeah, and we look across the body. There's 7 different movements. It takes about 2 minutes to finish, so it's very useful. And when we look at this criteria, there's 4 things in the toe touch. Can you touch toes? Are you using your hips to help you and your spine in some combination? Pretty easy to tell. And does it feel symmetrical throughout? So pretty straightforward. And then the big thing is, does it hurt or not? Okay? So let's say I got someone that has a perfect toe touch, but it's painful. It hurts. And then I have someone that has not so perfect toe touch. They got a few checks, but it's not painful. Well, which one are we going to work on? Really important. And that's the whole model here, is we are going to work on patterns that are not perfect. We use the word dysfunctional, so a pattern that needs some work, but that's not painful. I can bring in exercise and manual therapy to a non-painful pattern and make some big changes. Remember, pain's powerful. It's going to block things. It's going to create the inhibition that we talked about earlier. It makes exercise really hard. no pain, no gain may work in the gym, but it's not very often a rehab strategy to get movement back.
Yeah, absolutely.
And so across the body, we go for dysfunction that's been building up that's not painful. So if you have a bad back, it can only respond to what happens above and below it, right? So if your hip doesn't extend, your back's going to get loaded funny. If your upper back doesn't bend, your back's going to get loaded funny. So I may ignore your back for a couple of visits and treat your upper back and hip that don't hurt. Those get better quickly. Now I get that noise out of the way, get them moving, and now I can go in and treat the muscle. That's the problem. So that's the whole body approach, is get the microscope off that one little problem.
Yeah, we focus so much on the joint, but sometimes it's below, sometimes it's above, and we got to look at the whole human.
Yeah, and unfortunately, sometimes that muscle degenerates so much in the spine that we have to come back and locally treat it. And in this case, we're treating it very specifically by stimulating the nerve to the muscle. So we're going from very local specific treatment to a global treatment, and we need both.
I remember when we were in school learning about SFMA, and we learned that the ankle stiffness can lead to low back pain. And I'm like, that's far-fetched. Like, come on, really? And once we learned all the biomechanics, and we observed someone squatting, so say you got a barbell on your back and you're loading it super heavy, and you sprained your ankle 10 years ago, and you lack ankle motion, we call it dorsiflexion, your foot being able to come towards your shin. You squat down, your knee is not going to come as far forward as the other one, so you're going to cause torsional rotation at your low back. So you can develop low back pain from a stiff ankle. It's the wildest thing ever. And we fix people's ankle, get it better, and it's like, my back pain's gone. And initially when I learned this, I'm like, there's no way an ankle stiffness can lead to low back pain. But if you watch the movements and the way people move differently because of stiffness in a certain area, it'll compensate into another area of the body.
Yeah, body's very forgiving. It's going to compensate for sure. And the ankle bending variable is one of the strongest ones that we've identified, and I've done a lot of research in identifying what we just call risk factors throughout the body that do contribute to these injuries. And sure enough, if your ankles don't bend well, and actually if they don't bend the same, if they're a little different, right and left, remember the little sensors in your back? There's sensors in your back that tell your brain about core. There's sensors in your ankle that tell your brain what's going on. If that information's different, everything's off, and it is an individual factor for injury going forward for sure. So.
Yeah,
I'm checking my ankles right now.
I know. I see Jeremy moving his feet. He's like, my ankle's just as symmetrical. Tell me your thoughts on this, Dr. Joyal. How do people move differently when they're in pain? And how does all of this conversation relate to your practice?
I think by nature, we don't give up on ourselves very easily, so we're going to figure out a way to get tasks done despite some of the challenges we have, and that works for a while, but eventually that compensation that we find a way to do these tasks that would otherwise be painful breaks down, and as we compensate, we're maybe overloading certain areas and we're underworking other areas, and so it just throws the entire system out of balance, like you're saying there. So our job is the way we approach, these patients is to, with the assessment and imaging, is to understand what really is the common thing that looks like it's treatable that could lead to more productive, rehabilitation. Our interventions are useless without some post-treatment rehabilitation. We're not nearly as impactful. So we tell our patients that even though we can reduce your pain through these procedures, it's still important you make your body healthier with movement and rehabilitation with less pain, because that pain may come back at some point. So carpe diem, seize the moment, get better while you can, and we can continue to address things as our bodies age and adapt, and we get our next injury from our next hike or whatever. So.
Yeah. I completely agree. Is there anything you'd add to that?
No, that's well put. I mean, it goes both ways. I think the way I would describe what Dr. Joyal does is finds the driver that's really driving all this. Sometimes when we fix things above and below, that's enough biomechanical change on that tissue, it gets better. sometimes it needs a little help. And through imaging and his skill set, he can find that, and working together, knock out the source of the pain. We work on the cause, those biomechanical movement problems, and that's where you get the outcomes that you're looking for that can sustain and be help you get back to doing what you want to do. I mean, one thing you said, and it's just it is a treatment for chronic back pain. I hate this, but it is activity modification, right? And to think about that medically and as rehab providers, that we would use do a little less. If it hurts, don't do it. As a treatment is unfortunate that it's come to that. It can be that challenging. So I hate to think that we're going to limit folks doing what they want to do. Our goal is to keep them and getting them back to do what they want to do. So,
I have this CrossFitter right now, and she also shoes horses for 12 hours a day. And she's got this thoracic spine pain that she's had an RFA for, or radio frequency ablation. Didn't touch it. Like, she's had injections. We've done her PT. We barely touch her pain, but if I tape her with gluco tape, just really tough tape that doesn't allow her to flex her thoracic spine as she's shoeing horses, essentially taking the load off, it almost takes her pain away, right? So to tell her, like, modify your activity, it's like, well, this is my livelihood. I have to provide for my family. I'm a single mom. You know, she's not going to be able to just stop shoeing horses, you know, so figuring out a way to help them modify can be really important. And I don't know what the journey is going to look like for her yet. This was just yesterday. She's like, oh my gosh, I got so much relief from that tape. I'm like, thank goodness, because I was running out of options.
Yeah, you got to get a response before you can get an adaptation, right? Yep. So that little response, we do a lot of that, little tricks to get people feeling better. And now I've got a window to work with. Now, without pain in the way, the brain can help retrain these movement patterns, and that's the whole key. So getting a response is part of it, but that's the first step. Your job's not done yet.
Yeah. So we talked about the ankle and how ankle can influence the back. Tell me about the hips. What selective functional movement assessments do we do on the hips that could contribute to the low back?
Yeah, it's a good one. The hips, super important, right? Like we said, the poor lumbar spine just sits in the middle. It can't do much but respond to what happens above and below. And below, what we see in hip dysfunction that affects back pain mostly is a lack of your ability to extend your hip or go backwards. So when you take a walk
leg
and you're
going
moving,
behind you,
going behind
essentially you'd
you.
see a shorter step length with people that don't have enough hip extension.
Yeah, absolutely. So that lack of extension is a problem. And it's so common that people, you've got to just stretch the muscle in the front or do some glute activation in the back. And so you hear all these glute activation exercises. Sometimes a little more than that. You got to dig into a little deeper. Sometimes it's the hip extension deficit's driven from somewhere else. That's why looking at the whole body is important. And sometimes you need good manual skills to get in there. You think about stretching a muscle complex. Sometimes you have to treat the muscle. It's just lengthening it isn't really the answer. Sometimes it's knocking out a trigger point in that muscle, dysfunction in that muscle, and retraining the whole system. So hip extension probably is the biggest one that directly affects back pain. If you can't extend your hip, you're going to move at the small joints in your low back to get that motion.
Instead of allowing your hip to come backwards, you'll extend through your low back excessively, and you're just bending back and forth until it's causing irritation.
Low, extra wear and tear on a small little joint in your back, or sometimes your sacroiliac joint takes the blunt. And so by fixing big hip extension during walking and moving, we can relieve that tension. So
I love the joint by joint approach that you guys teach, because essentially every other joint is either mobile or stable. So your hip is intended to be very mobile, but if it's stiff, it will demand motion above that joint through the lumbar spine, and it will demand motion through the knee. The knee, although it is a mobile joint, it's technically more stable than the hip. So every other joint segment can be affected if one joint is stiff. So the hip, if it's stiff, even in rotation or in extension, it will demand motion through the lumbar spine, through your low back.
Yeah, everything's connected, and if you start the foot, you can work up and see this mobility, stability interplay. And what we tend to see are areas that should be stable that aren't, and they're kind of sloppy. And when they're sloppy, other areas stiffen up. So we don't always know what starts what, but what we see a lot is areas we need to loosen up so that other areas have a chance to be stable again. So,
yeah, I
absolutely.
love watching little kids move, little toddlers, because that's kind of how perfect movement looks. You can learn so much about these functional movements as you watch a child. But as we age, we have little injuries that come along, then we start to move differently. Or we have a certain work capacity where we're maybe working conveyor belt, and you just consistently do a movement over and over. Your body stiffens up based on the demand that you're requiring out of your body, and then you start to move differently.
Yeah, going back to looking at how babies develop movement is very eye-opening and helpful in terms of how we try to reestablish those what we just call fundamental movement patterns. Very simple things: balancing, touching your toes, squatting, even just rolling over. A lot of times in rehab, we got people down on the ground, on the floor, and we're working on fundamental rolling patterns to get the core sequencing to tap in like it was when the core control was developed as when they were a baby. So those things are very important. And yeah, there's wear and tear. There's scar tissue, things develop, time, and injuries that add up. And we're talking risk factors. One of the strongest risk factor of you having a future injury is the number and magnitude of the injuries that you already had, right? So if you've had the number of injuries and they've been more severe, you're more likely to have another one. And that speaks to those changes in the software and the motor control that we try to tap into in that rehab process.
Yeah, absolutely. And I'd love to go into more of the core stuff here. You hear so often, like, your core's not strong enough. Tell us what that means on your end, and then Dr. Joy, I'd love to hear from you.
Yeah, so that one's takes a while to unpack. It's
a very loaded statement, right?
There's a lot there. Yeah, I think the way we look at it from a functional unit perspective is there's deep core muscles and outer core muscles. Deep
so you're
core
telling me
muscles,
you could have a six-pack and still have a weak core?
Yeah, absolutely. I mean, the multifidus dysfunction we've been talking about, we see it all the time in very fit, active people. They're active and they're fit, their back just hurts. And their cores are strong. They do strengthening. But strengthening doesn't help you with inhibition and poor deep motor control, right?
So there's like the deep muscle stabilization, and then there's the outer muscle strength as well. So you're saying they could or could not be correlated?
They're just not connected. They get disconnected when there's pain. So back to the sensor problem in the muscle. When the sensor is inhibited and the deep muscle is inhibited because of pain, that sends a signal to the brain there's something wrong. That brain response is to splint the area that's painful with the big muscle activation. So what we see in back pain patients, and this has been validated in multiple studies, is deep muscle, decreased muscle activity, deep muscle inhibition, and outer core, big muscle, increase activity. So the muscles are splinting. So you're basically using your deadlift muscles to tie your shoe. Is a simple way to think of it.
Big movers to do the
small job, right? And that gets you through the day. Many of your listeners are dealing with that right now and getting by. It's just not efficient. It's not metabolically efficient. Big muscles aren't designed to do little muscle things. So you get fatigued faster. You set yourself up for the aches and pains. And if it was driven from back pain, you'll continue to fight that waxing and waning low back pain because these outer core muscles are doing too much. So one of the things that we do in the rehab process we talked about, through that full body assessment, we pick up these high muscle tone areas and we work through those first. I can't help your multifidus muscle in rehab if you're in a bad breathing pattern because you're tense and your traps are tense and your obliques are tense and your hamstrings are tense, right? So outer core muscles really need to be reduced, or we call it down trained first before we do anything else. And you get online and what exercise should I do for my back pain? You go to the gym and do planks and crunches, and you're just training muscles that are already doing too much. So
essentially, if I was to summarize that, your muscles are spasming, your low back the big muscle groups are tightening up to try to stabilize for the little stabilizer muscles that are not doing their job. And this is where we cue in Dr. Joyal to help us, because we'll use tools to, we call it modulating pain, down regulating pain, or down training, right? There's many words for that. But we use all these tools. We'll use cupping. We'll use, our manual therapy skills to push on the muscles, massage. We'll use A-stem, right? Like all the dry needling, all these tools to calm it down, but sometimes that's not enough. So Jeremy, tell us about what you do to help us with this process to be able to down-regulate those muscles.
Yeah, what's really interesting, and this is some of the research that the company did to produce Reactivate, is that it's not an effort thing at some point. The brain actually loses control over the multifidus muscle. In a normal, healthy muscle, they can measure what part of the brain is activated when the multifidus muscle is firing, and it's different from those outer core muscles. But somebody who suffers from chronic low back pain, there's no differentiation between those muscles in the brain. So the brain is just sending out signals, trying to engage anything, give me some help to move and stabilize, and that's where dysfunctional muscle comes. So it's really interesting in a clinical setting. We see these healthy people, they're marathoners, and they're just super active, carry a good body weight, but they can still have dysfunctional muscles, and we can demonstrate that on certain examinations. And I think those are aha moments for our patients as well, when they realize that, hey, I can reproduce your pain by doing an AP glide on your vertebrae, but when you lift your legs up off the ground, your big muscles contract and compress the spine and stabilize the spine. And so we can show them how they're dysfunctional and how that affects their pain. And
you just sounded like a PT.
Well,
that was really impressive.
I've been hanging out with this guy for 3 years, every time I talk with Kyle, I learn new stuff. So
never cease to impress me, Jeremy. Well done.
But that's something that I think patients can understand, and sometimes we have to show them that it's not your effort. It's unfortunately your body is not able to respond to as much as you want to. Sometimes you just need that extra help, and so that's why I'm really excited about the success we're seeing with the Reactivate device for this particular problem. So, and that it's a new treatment that launches an entire new field. There is not restorative neurostimulation. There wasn't until Reactivate came out. So, we're really at the just the very beginning of what restorative neuromodulation is, and so it's kind of fun to be at the the tip of the spear, so to speak, in that field.
Yeah, tell us what you both would like to see in the healthcare community working together on this. I mean, we got PT, in academia. You've been a clinician for many, many years. You've worked at the military. You developed all these movement systems for us. So you have a really good background. And then you have Dr. Joyal, who works in the pain medicine world. How do you see us working together as a team?
Yeah, it's a great question. I think efforts like we're doing today is a really big part of this. And one thing that we've seen been very micro-focused the last 4 or 5 years on helping Reactivate and help it get going. But even just getting different types of physicians that treat back pain in the same room has been pretty helpful. Like Dr. Joyal's training is through pain management. And we've got physiatrists that come through a little bit different window. We've got surgeons that come through a little different window. And getting them in the same room to say, hey, at the end of the day, the problem with the patient should drive what we do, not the discipline of the physician or practitioner that the patient sees. So interdisciplinary awareness, I guess, and collaboration has been great. I think for physical therapists, it's easy to talk to them about this. We're stimulating a muscle. Muscle's important. They nod. They get it. It's hard for them to feel like my patient's bad enough that they need this implant. Like sometimes there's that barrier. And because to a certain extent, we have to say physical therapy wasn't enough for this patient. And that can be challenging because you got a lot of pride in what you do and you want to hold on to your patients. And I would just encourage folks, just be realistic about it. 2 out of 10 of your patients probably need this. It would be what way I would say it. And you're going to get those patients back. And now the back pain's getting better. You can functionally work on all the things you want to work on. Get them back to doing the things they want to do. with minimal risk factors to keep them moving and really have that opportunity to engage in a well lifestyle and really consume wellness rather than consuming healthcare. Like that's my goal, is see these folks get back.
I really think that we can improve that in our profession.
Absolutely.
Sometimes we get a little too prideful and we just think we should get every patient better in physical therapy, and we don't need anyone else. We call it the silo care, right? Our profession really needs to step to the plate and say, especially in Utah now, we're primary care providers. We passed that bill. We're the first in the nation to do it, and it's a huge responsibility, but it also comes with knowing when to refer. We need to utilize our team. We need to utilize each other for the best outcomes of the patient. We need to get rid of this silo care. It's like, oh, I can get every patient better. And like, we really got to look long term. Is this going to be a long term solution for this patient? Or are they going to graduate PT and all this is going to come back in 2 months? You know, and they thought, oh, PT didn't help. There's some missing pieces there.
Yeah, that's what happens. And the patient very typically does well with PT for a while. Like, they feel better, they're treated well, they feel better. Maybe it's months, sometimes years. They have a setback, and they're like, I don't want to go back. Have I been doing my exercises enough? And they sort of internalize it, and they'll take that responsibility and go, I'm not doing my exercises. I really don't want to go back. And then all of a sudden their back's hurting, and they'll go seek care with another provider, and they'll end up somewhere else. So that just true transparency of what we do and how we can all work together for that ultimate goal is super important. Yeah.
Love it. What's your thoughts, Jeremy?
Yeah, that's exactly what I hear on a regular basis. You know, I've been stuck in this cycle of periods of wellness. Then there's a setback, so I go get treated, and then whether it's, you know, with medications, therapy, or injections, or the other treatments, and the patients just can't exit that cycle. And so that's what's really exciting about Reactivate, is that it's something that we should be employing pretty early. If somebody is not getting functionally better within 6 months, we know from the histological studies that I referenced earlier that the muscle fibers are changing. They're going to become more stiff. Then the brain isn't able to get that feedback, and then that's where that brain shift happens in controlling the other muscles, and then that just leads to the whole downward spiral of long-term chronic back pain. You know, so I would love to see, you know, it starts, you know, right here with us. You know, we treat patients in the same community. In fact, you've treated someone very close to me. You know, and so. So working together as a team is key, but also recognizing, I think for this particular problem, the 6-month mark is really where we see long-term changes potentially becoming irreversible. And that leads to, you know, more healthcare utilization. As Kyle says, their life gets smaller because they stop doing activities that lead to setbacks and so on and so forth. So I would love to see, you know, this therapy become more of a mainline treatment in patients who really in their 20s and 30s should be able to rehabilitate. And if they can't, I wonder at this point if they were to be introduced to this therapy, the Reactivate device, at that age, do we get to exit them from that world of chronic back pain, you know, and avoid it for years and years and years.
Yeah, and prevent that trigger into chronic pain. Like we say, to me, chronic pain is one thing. Chronic back pain is something else, right? And if you get triggered all the way to chronic pain, and you're driven with those psychosocial pieces that come with that, it can be very challenging. There's a lot of people out there that they have had back pain for a long time. Psychosocially, they're pretty squared up, but they just aren't engaging in their life like they want because their back hurts. And so if we can catch them before it triggers into the chronic pain world, that's super helpful. So that's I agree with the goal long term, kind of where we're going. More for me personally, more than looking at other parts of the body with this, I'd like to see it moved sooner in the process.
The front lines.
Yeah.
At like 3 months. You know, like the thing is, we have this acute phase. Typically, we define that as 0 to 30 days, which is the easiest to get people better in the PT world.
If you get them in time.
Yeah, if I get them in my clinic, they start therapy. But we all know that's not necessarily the case. And we're trying to change that model where people recognize PT as the first line of defense, and they go to them within the first couple days of having low back pain, because we can reverse it really fast. And then there's the subacute phase, which is like the 30 to 60 days, which is typically when we get people because they've gone to the emergency room or urgent care, then their physician or their primary care physician, and then they get medication, and then they're sent to a pain physician, and then you send them back to us, right? So it's just like this long journey of getting back to us. But what we're doing now is we're saying, come to PT first, get the treatment in the first 0 to 30 days, and then if you're not getting better, we need to get you to other places quickly and move the needle faster so you don't get stuck in this chronic cycle, because once you get to that 90-day mark of having low back pain, it literally changes the physiology of the brain, the biology of the brain. It reshapes how you interpret pain, and you stay in those cycles for significantly longer.
Yeah, and if you dig deep into the outcomes research, 6 months is a mark, as Jeremy mentioned. Another mark's 12 months. So if we catch you before 12 months and you're in the right hands, we've got a chance. Past 12 months, it's challenging, and I think the brain changes that Dr. Joyal mentioned are a big part of that. But yeah, absolutely, earlier is always going to be better.
Yeah. Tell me about so say our listeners like, man, this treatment, Reactivate, sounds like I need to do this. Tell me the criteria.
So we're really focusing on non-neuropathic pain, so not your typical sciatica presentation. So it's a central back pain right in the spine, right above the belt line.
So they don't have leg pain as well.
Correct.
Is what you're looking for.
Yeah. If they have neurological symptoms, this isn't where we would start. But they have done their therapies, and I dig into that a little bit. I like good therapy, not just therapy, because we know there's some poor providers out there, and
like every field.
Yeah,
unfortunately.
That's true. So that being said, I want quality PT, and if it hasn't happened yet, we're going to get patients into quality PT. Use the anti-inflammatory medications or hopefully non-opioids to facilitate working through the PT, which should be somewhat uncomfortable. We want to break down some deficits, and that's going to come with some short-term pain, and so we want to help through that. And then it's essentially patients who have either atrophy of the multifidus muscle on an MRI finding, or we can demonstrate instability through physical exam findings in the clinic.
So that's the only criteria. That's pretty simple.
And at least 6 months of going through
at least 6 months of
good therapy.
Treatment.
Yep.
Got it.
Yep.
Yeah, and I really want to emphasize, we talk about good therapy. What are the things that you look for to determine if it's like, that didn't sound like the good therapy that we typically want?
Yeah, if patients tell me, I don't know that I get much from my therapy, I say, well, what'd you do? They put me on an exercise bike, and I did that for 30 minutes, and then I laid on got a hot pack and a cold pack.
That hurts my heart.
And then I went home.
People are getting that so much.
Yeah.
It's so terrible to hear from our profession.
Yeah, so we're looking for somebody to do a comprehensive evaluation, like what you guys were talking about earlier, just to make sure the head bone can connect to the foot bone, so on and so forth. And then hands-on approach, working with the patient and not just sticking them on an exercise machine, but working through the therapies. Also, therapists that can provide those manual therapies that you mentioned, the A-stim, the dry needling, E-stim, all of those things, I think have been very helpful for a lot of our patients. And
yeah, I love that you're curious and you ask good questions to determine if they got good therapy. Because so many physicians that I know will say, have you been to PT? PT can be defined in the patient's mind as so many things. Mm-hmm. It could be, I YouTube a bunch of exercises. PT can also be defined in Utah, unfortunately, as in a chiropractic office. They can actually, in their scope of practice, they can define it as physical therapy. Mm-hmm. So even knowing they're a chiropractor, people think that they got physical therapy, which is very different, right? They can also think massage. They can also, there's so many things, but you actually dig into, tell me about your physical therapy.
Correct, because I certainly don't want to venture into unnecessary procedures if those therapies are going to be helpful for the patient. That's just going to lead to bad outcomes. So we definitely dive into that, and if we haven't seen that, then we work with our good folks like you in the community that help us get that question answered. And then working with insurance providers, they actually have started separating it. Chiropractic treatments for some of the insurance companies in our area consider that other treatment, and then PT is a separate requirement. So,
That's great.
It is, and we're glad we have good providers like you and your team. So
yeah, that's great. So last question for you, and then I'd love to hear your concluding thoughts as we wrap this up. When we're talking about all of these issues, what are some things that PTs typically miss that you would kind of highlight, like what we need to be more focused on in the PT community in the beginning stages? We're talking about good PT versus not good PT. What are some things that you would see that are typically missed?
Yeah, it's a good question. If we keep it in the realm of back pain, I think identifying a pathway for each patient. So whether you are trained in a given system or not, you're going to individualize that care from the beginning, and you're going to identify things that are grounded in the evidence that you can individualize with that patient. So it's individualized evidence-based care. It's really where it's what you do. That's where we need to go. I think sometimes we get a little too into the evidence and kind of hide behind the evidence and say, well, here's the criteria that was in the study. You've come close enough to meeting the criteria, therefore someone technically go execute that protocol, right? And that's not individualized care, even though it's technically evidence-based care, and you're going to get sort of average results from that. I think the other thing is, honestly, our profession shifted a bit away from the physical part, and I think there's a big piece there. I don't know if this is the appropriate place to unpack that, but I do think physically working with patients, therapeutic exercise, and manual therapies are still grounded in good evidence. So
yeah, you see,
I think seeing
we
that
always
right
talk
away,
about this pendulum that shifts through generations, right? We had this big push in my early career that's like, do all the modalities. It's like, I remember as an aide, I was doing ultrasound.
Oh, yeah.
I was doing electrical stimulation, massage. That was like 40 minutes of the treatment. And then we do like 10 minutes of exercise.
General stretching or some general exercise.
And now like there's this huge pendulum that shifted to this younger generation of PTs. It's like, you load them, get them under a barbell, like deadlifting, right? Which it's creating its own issues. Like the pendulum swings way too far, but ultimately we got to create a balance. And I love that you say customized care. I've had plenty of colleagues reach out to me in the past in other professions, other than PT, say, can you give me a list of low back pain exercises and give my patients? And usually I'll say very kindly, I'll say, like, can you give me your glasses and they work for me?
Yeah.
Like, it just doesn't work that way.
No,
You can't just YouTube a bunch of exercises that are going to help you specifically. We got to down-regulate your pain. We got to customize the care. Sometimes it's hip mobility issues. Sometimes it's thoracic spine mobility issues. Sometimes it's stability, right? So I could give one patient a list of exercises and it actually hurts them. Actually makes their symptoms worse, but I give another one and it helps them a lot. But we got to consistently tweak those throughout the plan of care. And that's why I love PT so much, because I get to see people through a period of time and how they respond to the stimulus that I give them. And then I make adjustments. And that's where you talk about customize. We can't lose the customization, right? And people talk about AI taking over PT. And like, AI will never take away PT as long as we customize care.
Yeah, absolutely. And I've just can't tell you how many times I've had to dodge that question. Hey, Kyle, just send me the multifidus exercises. I'll give it to my patients. Good thinking. I appreciate that we got you thinking about muscle dysfunction, and that's part of what we do. But it just really depends. I mean, bottom line, as you said, we have to go through the whole process. Curbside care is what it is, and it just doesn't work too well.
Yeah. Love to hear concluding thoughts as we wrap up the podcast. Any other thoughts you'd like to share?
Well, I think I'm just really excited to be able to share the message of this, new therapy that is the paradigm shifter in actually restoring some health instead of just palliating pain, so to speak. So that's what I'm really excited about. And
give people their life back, right? Like
100%.
Give them, not just anesthetize the pain, not just anesthetize, like fuse it, but we have other options, because all these tools play a role. But this is a good just prevention piece, right? Where you can save all the unnecessary medical expenses later on, and it gives people the control again. I love it so much.
That's exactly right. And then, I would just say that working with good community partners has really driven our field to get better, in both directions. And so we'll just keep doing what we do, brother.
Yeah, I love it. Any other last thoughts?
Yeah, I think for the listeners, I mean, you're out there, you want to be active, you want to do things. If something hurts, you need to get it taken care of. Get some attention, find a good healthcare provider, and you really sometimes a team to help you with that. And don't let don't give in, right? Keep doing the things you want to do. Find the right help that you can. And sometimes that takes more advanced therapies if you're that far along. And the good news is we're moving in these directions. And I wouldn't say it's technology that's driving what we're doing, really. Our therapy that we're talking about, Reactivate, is quite simple. It's a battery and a couple leads that stimulate a nerve. It's not that complex, but it is certainly effective in getting you back to what you want to do. So be an advocate for your care and get that understanding. But our goal is to get you back to doing what you want, because then, as I said, you can consume a well lifestyle, which helps quality and quantity of life, and that's what we're here for. So
yeah, I love that. And ultimately, I would say if you have spine pain and you don't have a team approach, you're not really doing it the best way. Every spine clinicians, physicians that I know work together in a team. And the more I've treated low back pain more than anything else in my career, and the more I've noticed about it, everyone's so different, and we have to have a team. I can't fix them all. And I've come to that conclusion and acceptance. Like, it is not my job to fix all low back pain. We have to work together in a collective team, because each one of us have pieces to different spine care, and if we're not working together as a team, we're not doing it right. So where can people find more information about Reactivate and anything else, any other resources you'd send them to?
Is it mainstaymedical.com?
Yeah, easy to find. Just do the Google thing, right? Mainstay Medical or Reactivate, spell it out. It'll come up. And then, of course, around here, Dr. Joyal's office got plenty of folks that can help educate. And
I think it's Reactivate with an actual number 8, right?
Reactivate with a number 8. Yeah.
And then we have links on our webpage. We're at asappainclinic.com.
Awesome. Well, thank you both for joining us today. And seriously, so much gratitude for all the work both of you have done throughout your careers. I mean, I think about the giants that I build my career upon. That's you guys. Kyle, the work that you've done has just been incredible.
Yeah, thanks. And as I said earlier, it's nice to see it kind of make its way to fruition in the clinic. And it won't be long, and I'll be riding up to Montana and call it a career. So. Well,
I love it. Well, thank you both. And Jeremy, thank you so much for you do for our community. You're a leader in the industry, and you're just such a light to work with. And I feel just fresh air every time I work with you. Nice. And you create a safe space in which we all can exist.
Yeah.
And it's so refreshing to have a physician that's supportive of all services, that see a part and a role that everyone does and values that, and we work together as a collective team. So thank you.
Well, vice versa. Thank you. It's we see great outcomes together.
Well, thank you, Gordon, for joining us. Appreciate it.
Thanks.